Hello, medical students. Today, I will discuss anal fissures, a common and painful anorectal condition frequently encountered in clinical practice. Definition and pathophysiology. An anal fissure is a longitudinal tear in the anoderm, typically located in the posterior midline of the anal canal. The fissure is often a result of trauma to the anal canal, which may occur due to hard stool, prolonged straining, or frequent diarrhea. Increased internal anal sphincter tone and poor blood supply to the posterior midline contribute to the development and persistence of the fissure. Anal fissures are classified as acute or chronic. Acute fissures are superficial and heal within 6 weeks, while chronic fissures are deeper, may have associated sentinel skin tags, and are often more resistant to conservative treatment. Clinical presentation. Patients with an anal fissure typically present with severe, sharp pain during and after defecation, often described as tearing or cutting in nature. The pain may last for several minutes to hours after a bowel movement. Bright red rectal bleeding, often seen as streaks on the stool or on toilet paper, is also common. Chronic fissures may present with associated itching or discomfort due to sentinel skin tags. Diagnosis. The diagnosis of an anal fissure is primarily clinical. A careful history and physical examination are essential. On inspection of the anal region, a tear is usually seen in the posterior or anterior midline. Digital rectal examination is often avoided initially due to pain, but gentle inspection can help confirm the diagnosis. Chronic fissures may have raised edges, visible muscle fibers, or sentinel tags. Management. Management of anal fissures depends on whether the fissure is acute or chronic. Initial treatment is conservative, aimed at reducing pain and promoting healing. This includes dietary modifications like increasing fiber intake, ensuring adequate hydration, and using stool softeners to minimize trauma during defecation. Topical treatments, such as nitroglycerin ointment or calcium channel blockers, e.g., diltiazem, help to reduce internal anal sphincter tone and promote healing. Sitz baths with warm water can also provide symptomatic relief. For chronic fissures or those that do not respond to conservative measures, more invasive treatments may be required. Botulinum toxin Botox injection into the internal anal sphincter can be effective in reducing sphincter spasm and promoting healing. Lateral internal sphincterotomy, a surgical procedure to partially divide the internal anal sphincter, is considered the gold standard for chronic fissures with a high rate of healing and symptom resolution. Take-home message for doctors. Anal fissures are a common source of severe anal pain, particularly during and after defecation. Early recognition and appropriate management can significantly improve patient outcomes. Conservative measures are effective for acute fissures, while chronic fissures may require medical or surgical intervention. Always aim to relieve the patient's pain, promote healing, and prevent recurrence by addressing contributing factors like constipation. Thank you for listening, and continue expanding your surgical knowledge.